But welcome everybody that's already here. I can see we've got over 70 people here already. Got a few more people who've registered, so we'll just give people another minute or two to just get into the virtual room. It's very strange to see the numbers go up without seeing the faces that accompany them, but we're all getting used to that, aren't we? So it's great to be here with you this morning. Do get yourselves ready. It looks to be a very, very good, full and interesting event this morning. Okay, give people another minute because the numbers are still going up. Hello, everybody that's just joining. Welcome. It's nice to know that so many people are here with us this morning and are interested in the topic that we're going to cover this morning, and in thinking through and planning and doing differently around early intervention in psychosis. It's really exciting to be here with you all this morning. So I'm going to get started just as people are coming into the room. So welcome everybody, welcome to this early intervention in psychosis webinar, which runs from now until 12:30, and you can see from the welcome slide that we have there that we've got a good packed agenda, and we hope that you'll all be enjoying listening, learning, thinking and going away and doing differently from what you hear this morning. For those of you that don't know me or don't know me yet, my name's Rachel King and I am the portfolio lead for the mental health improvement portfolio at Healthcare Improvement Scotland. And I'm delighted to be opening this event this morning. Early intervention in psychosis, the programme is one of our national programmes within the mental health improvement portfolio. We're lucky enough that this is a programme that's been running now for over 3 years. We had a phase 1 of this programme where we looked at the needs across Scotland, where we looked at the current picture across Scotland, and when we really came to an understanding about in what ways could we implement evidence that works for people and utilise the evidence base to do and think differently around intervening early in psychosis in Scotland. It is still a national priority, and we have had funding agreed for this phase 2 piece of work where we are doing some of the support with local areas to help them deliver early intervention in psychosis and to get services off the ground and into part of their mental health system. We have funding from now until the end of March 24 to finish this phase of implementation and learning, and these webinars are part of that. It's about getting together interested people like all of you here today to focus on some of the key issues that we see around psychosis and to really be able to go away with a better and a deeper knowledge and understanding, as well as an opportunity to join with colleagues and peers to think about how that might make change happen for yourselves. We know in intervening early in psychosis that the evidence is clear. We know that by doing early intervention, we lead to significantly improved outcomes for people. So we're looking at designing and delivering EIP services across Scotland, and this is part of that work. So thank you for being with us on this journey, and thank you for being with us today. You won't be hearing much more from me today, but as part of this webinar, we will be hearing from speakers with a great deal of knowledge and a great deal of experience in this field, and they are Professor Matthias Schwannauer and Professor Ian Kelleher. And they will be introduced in a moment. But first of all, before we do that, I'm going to get to do the housekeeping. So you will see that everything that is happening throughout today will be up on the slides, that by being here, you are consenting to the recording of this session. We won't be using anybody's names for anybody that's asking a question at any point or making a comment at any point, but we do find it helpful to have this recording so that we can bring together a summary report, and we will make resources available following the session. For those of you that maybe haven't used Teams so much before, there is a chat function, so do put comments and questions in the chat, and they will be brought together by our clinical leads, who are Susie and Rajiv, who will be looking at the chat throughout the session, and will be able to formulate some of the questions for the speakers. So the other thing that I would say is turn cameras off and put mutes on just at the moment, because often we get feedback if people don't have mutes on, and with cameras it could be just you and 100 and odd people, so it's usually better to keep your camera off. The first person that is going to speak today is Alastair Cook. Alastair is Principal Medical Officer for Mental Health. He is an advisor to the Scottish Government. He has a breadth and depth of experience in working in psychiatry, and we're really delighted to have him here with us this morning. So Alastair, I'm going to hand over to you, and thank you everybody for being here, and see you at the end. Thank you.
That's brilliant. Thanks, Rachel. It's really it's an honour and a pleasure to be here and to introduce the session today. As Rachel said, I'm Principal Medical Officer in the Mental Health Directorate at the Scottish Government, and have a history of working clinically in psychiatry, but more so as a medical manager across services over the bulk of my career. I'm going to talk to you a little bit about where I think we've reached in terms of EIP, and go back a little bit in history. For some of you, it'll feel like ancient history, but I did my psychiatry training in the early 90s, at a time when we were beginning to see the introduction of what were then called the novel antipsychotics, and the development very much of an understanding of what psychological therapies could offer in the treatment of psychosis. And I remember being really struck by the analogies that were being drawn at that time about the early intervention in the treatment of psychosis, and drawing a parallel with treatment of cancer. And so, you wouldn't imagine a situation where you would allow a cancer to reach a point where somebody hit a huge crisis where it was impacting on their functioning before you would think about intervening. And why would that be the case for psychosis? It felt instinctive that you would want to intervene as early as possible. And we know that the work that was being done at that time in the pioneer services very much demonstrated that outcomes could be improved by that early intervention, using that biopsychosocial model. I was sort of vaguely aware of the introduction of esteem in Glasgow in 2002, arising from some of the work, and had colleagues who had gone and spent time in, particularly in Australia, looking at services there, who came back with their learning and introduced some of that. But in policy terms, I think the relationship of Scotland with the concept of early intervention and treatment for first episode psychosis has really been it's been a long drawn out process, and going back, one of the things in delivering for health in 2006, we committed to the development of integrated care pathways for a number of conditions, and in the ICP standard in 2007, which was a piece of work which I had the privilege of chairing. But at that point, we were saying that in the early stages of schizophrenia, an early intervention model of care should be delivered. That's what, 16 years ago now. And then there have been a whole series of policy commitments or drivers over the years towards the development of early intervention in Scotland. Go back in 2012-15 strategy. I think worth quoting the actual commitment that was made in 12-15, that we would identify the key components that need to be in place within every mental health service to respond to first episode psychosis, and encourage adoption of first episode psychosis teams where that was sensible from a geographic perspective. In 2013, we had the Signed Schizophrenia Standards, which set out a requirement around early intervention. In 2017, we again had a commitment within the mental health strategy. And on that occasion, it almost seemed to sort of go backwards slightly, because we then said we would ensure the propagation of best practice for early interventions for first episode psychosis according to clinical guidelines. And that, I think, is the driver for the move towards his being asked to take forward the piece of work, which was commissioned in 2019 and which, as Rachel set out, is now in its third year of progress. In the meantime, our colleagues south of the border moved towards an access target for early intervention services, introduced in 2016, saying that 50% of those suspected of having a diagnosis of first episode psychosis should be allocated to a team able to deliver all the components of an early intervention team, and allocated to a care coordinator to do that. So I suppose in the few minutes that I've got with you this morning, I just wanted to think a little bit about why so long, and what now, and the why so long. I think part of it is that we've struggled a bit with the concept of the specialist teams in Scotland, and how that would work within our geography. But I think more fundamentally than that now, this week marks 10 years since we introduced the access targets around psychological therapies and child and adolescent mental health services in Scotland, which at the time were the first access targets to be introduced in mental health services in the UK. And at the time, those targets were very much identifying where there were significant gaps in our mental health offer to people in Scotland. There were very poor provision of psychology and psychological therapy services, and we know that our provision to children and young people was poor at that time. And I think those targets were very, very helpful in their initial stages in driving priority and investment, but increasingly have become something that has become the be all and end all of our work in looking to mental health service performance, and perhaps have detracted from some of the other areas that really needed attention. And it's just a personal view, but I think potentially some of the work that could have been done around, for instance, the development of community mental health teams and the development of early intervention psychosis has been a victim of some of that focus. So where do we go now? We at the moment we're working on a new mental health strategy for Scotland. It will be published in May or June. Their suspicion is that it may well be part of the suite of things that a new First Minister will choose as his first to deliver within his first 100 days. As it's drafted at the moment, it sets out a really bold ambition with a vision of a system that encourages better population mental health, increased access to low-level interventions and self-care, increased local availability of support care and treatment through primary care mental health model. But it also needs to look to us to create a refocus on how we support people who have or who are developing potentially severe enduring mental illness. And I think within that, we want to, what the phrase we're using is a reimagining of what CMHTs are expected to do and what they can do within that. Of course, particularly for the focus today on children, on young people and transition, how people transit from CAMHS services into CMHTs will be a hugely important part of that work around the reimagining of CMHTs. I think the work is around this in early intervention in psychosis and some of the other programs that his are taking forward will be really influential in us in us looking to implement how an EIP model can be implemented across Scotland with all the different geographic needs and models that there are about. I think these events are really exciting. They offer us the opportunity to learn from the experts, and the fact that we've moved to the online system means that large numbers of people can benefit from these events in a more practical way than perhaps they could have done before. It's one of the few benefits I think that we have got from the COVID pandemic. I'm really looking forward to hearing our speakers this morning and to learn a lot from what they have to say. And I will stop going on then and introduce our first speaker, if that's okay with everybody. So, Professor Matthias Schwannauer is Head of School of Health and Social Science and Professor of Clinical Psychology at the University of Edinburgh. Consultant Clinical Psychologist in Child and Adolescent Mental Health Services in NHS Lothian. His research groups focused on investigating developmental trajectories of mental health and well-being across the lifespan and the development of current psychological models of emotional distress and mental health. Matthias is particularly interested in the advancement of specific psychological interventions, in particular implementation of mHealth and eHealth applications. His research interests look to further our understanding of the development, adaptation to, and recovery from severe mental health conditions, particular psychosis and recurrent mood disorders, with a particular focus on psychological and developmental transitions, both from childhood into adolescence and from adolescence into early adulthood. Matthias, look forward to hearing your talk, and thank you.
Thank you, Alastair, and many thanks for the invitation to the network to give this presentation. I haven't had a chance to be part of any of these meetings before, so some of what I might talk about may feel like a rehearsal of information you already heard. I'm not very good at multitasking, so I'm just going to pause and share my presentation so you can see. I hope you can see the slides and you can hear me okay. So yeah, Alastair, many thanks for the introduction. I'm not going to say anything else about my background and context. The presentation today, I really want to focus on adolescent onset psychosis and the treatment of early psychosis from a child and adolescent mental health perspective. So some of the things we know from early intervention psychosis services and research more generally, but I think it is worthwhile to highlight some of the key aspects and components from an adolescent perspective or young person's perspective. And I try and explain why I think this is particularly important and vital in that context. I will then talk a little bit about some of the work that we've been doing in terms of a both service approach and an individual treatment approach that focuses particularly on some of the developmental vulnerabilities that present themselves in adolescence and how we might capture that within a sort of novel treatment context. I think the opportunity of refocusing on early intervention in psychosis in Scotland also gives us the opportunity to look at our treatment and care models and to be quite innovative in that respect. And I hope to highlight some of the advancements that we were able to make. Alastair actually rehearsed this, so I will be very brief. The early intervention in psychosis paradigm or framework is very much based on early research-led early intervention services that in essence created very positive clinical outcomes that kind of caught the attention of provisioners of services as well as clinicians around the globe. In the UK, we saw the introduction of the early intervention psychosis services as a national service framework, and then the mental health policy implementation guide, or PIC as kindly referred to, that really looked at the rollout of early intervention psychosis for all. And this was picked up in subsequent policy documents that kind of reinforced that point. And as Alastair said, a kind of shift more laterally to access and outcome targets rather than the provision, which I think is quite an interesting shift in perspective. And clearly an impetus or a wish that all young people who develop a serious mental illness will be in receipt of early intervention services throughout. Some of the key research findings that kind of fueled this impetus and that fueled the wish to make this available to all is that we learned that delayed treatment, so the kind of delayed recognition and appropriate treatment of early psychosis, has serious consequences for individuals and their outlook. And this is partially why this group was targeted, because individuals suffering from psychosis or schizophrenia were some of those who had the most fundamental impact in terms of their participation and contribution to society, as well as individually in terms of individual development. We do know and have learned that early intervention, when done right and applied right, can reduce long-term morbidity, and that includes morbidity as in the early death that we see in sufferers of psychosis and schizophrenia, the relatively high suicide rates, but also in terms of ongoing and residual distress in the long term. We know that late intervention and the linked disability to it is very costly for us as a society, and most importantly for families and individuals. We see a substantially reduced life expectancy with tau, and I think if these figures were placed in any physical health context, as Alastair said, I think it would see a very different public health response. NICE summarized in their schizophrenia guidance, early intervention services, more than any other service developments to date, are associated with improvements in a broad range of critical outcomes, including relapse rates, symptoms, suicidality, quality of life, and a better experience for services. So a very compelling case. We do know that this is particularly important for adolescents, for whom often the onset of psychosis or schizophrenia sort of, kicks their development right in the shins. It's usually at the end of school or the start of work or further education. It's usually when people become more independent and individuate from their families, and when young people kind of start to build an independent life. And having a psychosis and associated treatments is not very helpful. So we see the onset of psychosis significantly interfering with psychological and social development, building independent relationships, peer groups, building future planning and so forth, a disruption of study and employment, a real loss of self-esteem and sense of agency of what you might feel able to do in the society and how to contribute. A significant increase in risk of depression and suicide, which is often labeled as sort of a comorbidity in psychosis, but may well be part and parcel of the early presentations. Often undesirable pathways to care with forced admissions, long hospital treatments, and really disruptive care pathways, which again are costly for the individual and us as a community. We see increased substance misuse, an increase in violence and criminal activities, strain on relationships, family distress, huge incidence of secondary trauma, slower and less complete recovery than compared to adult onset psychosis, a perceived treatment resistance that usually an early onset is associated with poorer prognosis and outcomes in this group, and an increased cost of management because of the additional socioeconomic consequences. Early intervention therefore aimed to highlight the possibility to prevent psychosis in an ultra-high risk group. So the idea that the earlier we can intervene, the more we may be able to buffer some of these detrimental negative consequences, to reduce the duration of untreated psychosis, so the length of time that an individual who experienced an onset of psychosis may go without recognition and treatment, to optimize the initial experience of acute care and treatment, to put that in a much more collaborative and reciprocal framework for people to feel like they're genuine participants in their care and can contribute to it, and to maximize the recovery and prevent relapse during a critical period of development. Because we saw this national rollout, we also have very strong data on sort of large-scale evaluation of early intervention in psychosis, and this has been well publicized, and I don't think will be new to people in this network by the Department of Health in England, but it's worth highlighting, particularly from an adolescent perspective, of what that means for young people who have not yet established a kind of independence, life, and career, and so forth. We know that 35% of people under early intervention psychosis care are in employment, compared to 12% of people in standard mental health care or CMHTs. It reduces the probability of somebody being sectioned for treatment and admitted to hospital under section from 44% to 23% in the early months of psychosis. And there have been very robust several health economic evaluations that, in theory, early intervention for psychosis should pay for itself very soon. So if everyone who was eligible received early intervention, it could save the NHS 44 million each year, and I saw a recent evaluation that put that up to 60. Most importantly, in terms of the direct consequences for families and individuals, early intervention support reduces the risk of a young person taking their own life from up to 15% to 1%. Over 3 years, in the early Macron report on the health economics of early intervention in England, the cost per case was calculated as over 26,000 in early intervention and over 40,000 in community mental health care, which is a significant saving per case. If you compare this to the kind of investment we see in other public health interventions, and that red circle actually moved, I'm very sorry, the early detection of psychosis and early intervention in psychosis, so it can lead to a 10-fold to 18-fold return of every pound spent. And that's right up there with some of the most successful public health interventions we saw around alcohol use, suicide prevention strategies, and so forth. So something that from a health economic perspective and from a public health perspective should really be a no-brainer. And Alastair already went through this, so I won't, but there is a commitment within Scotland to early intervention psychosis, although not quite as specific and distinct as we saw in England. Now, adolescent onset psychosis, as I mentioned, sort of happens right at a critical period of individual development. And the top graph is well rehearsed from a WHO report that mental health in late teens to early adulthood is the biggest contributor to burden of disease. And I think within services, we all can observe that, particularly post-pandemic, in terms of a resurgence of significant increase in help seeking for mental health. And that mirrors the onset of psychosis, which for both females and males sort of seems to sit around late adolescence to early adulthood, with a kind of significantly earlier onset for males and what that might mean in their development. We also know now that adolescent onset psychosis, or early psychosis in general, doesn't necessarily have a kind of distinct onset. It's not something that happens overnight, somebody just wakes up with. It's usually a kind of slow and developing, exacerbating course. Larson sort of characterized it as sort of a premorbid phase, very early symptoms where we may target early detection and intervention strategies, the onset of psychosis and the clear development of psychotic symptoms or experiences, and then early intervention that should really kick in as early as we can, leading to kind of treatment and recovery within tertiary services and relapse prevention over a longer period of time. And it's that duration of untreated psychosis, so the period of time between the emergence of early symptoms and their consequences for individuals' lives and their interaction with their communities and relationships, and the development of full psychosis. That seems to be the kind of key critical period where we should place our intervention. And in the literature, there's lots of debate where early intervention services should start, whether these ultra-high risk individuals that haven't yet developed psychosis but present with ultra-high risk mental states should be included in early interventions, whether they should be seen in separate services. However we do it, we know that this is the critical period for their prognosis and future outcomes. We also see a differentiation of psychosis over that critical period in differential time. And one of the key aspects that makes it particularly difficult to recognize psychosis early and to identify appropriate treatments and assessments is that it's a bit of a mush at the start, that often young people present with a mixture of emotional and psychiatric distress that doesn't as clearly differentiate into different diagnostic classifications as it might later on. So this is something that develops throughout the phases of psychosis right in that critical period. And one of the key consequences of that is that maybe early intervention services and approaches should get less concerned about diagnostic certainty and more concerned about attending to the individual need, however we best describe it in medical terms. We also know that from an individual perspective, we see many precursors in that early phase that contribute to the development of psychosis. We see an impact on individuals' cognitive abilities. They find it more difficult to pay attention or maybe are observed to have difficulty in learning, staying in school. We often see an increase of anxiety, personal unease, sort of flattened affect, early signs of depression. We often see a lot of social withdrawal and sort of zoning out and leading to social isolation, educational failure. All of these are precursors before first psychotic symptoms are reported or observed. One of the problems we have in terms of our formal assessments and approaches to early psychosis recognition and treatment is something that Joseph Bergson observed in the 1950s, and it's since been labeled as the Bergson's bias. It's basically that there's a very strong treatment-seeking bias. Most studies and most research that we lean on has been developed within clinical samples which were already in treatment, already diagnosed, and already help-seeking. And we do know that the kind of symptom formation and that kind of phase development looks very different at a kind of earlier stage of the illness. So a lot of our models of understanding actually emerge from a retrospective bias of what an illness might develop into, rather than how psychosis may start. So the idea of a kind of syndrome may be illusionary, because help seeking and the need for care is a key confounder, and that we're actually basing a lot of our understanding on a highly selected group where there's a lot of comorbidity. This has been observed more recently than the 50s, particularly in psychosis samples, where that overlap or that coexistence, for example, of delusions and hallucinations, two of the key positive symptoms that define psychosis in that, or schizophrenia rather, in that group, are very strongly associated in help-seeking groups, but in a general population, they're rather independent, even though the experience itself may look very similar from an individual perspective. We also see this in our very early understanding of psychopathology from a kind of Kraplinian perspective, who based a lot of the early classification and diagnostic understanding of severe mental health on observations of populations in psychiatric asylums, where we see a very clear differentiation of what he called dementia precox, or schizophrenia, bipolar disorder, and other common mental health disorders, including depression. Whereas if we look at a more modern view on mental health, and we look at a community level, for the same reason of a kind of phasing model of development of the disorder, we see much less differentiation, and we see much more overlap of different symptoms of distress, which I think can be a real problem. And I will hopefully get a chance to talk about some data we have from CAMHS services that, this may be some of the reasons why actually the duration of untreated psychosis in an adolescent onset group is often within service. So these are not people that are in the community, not recognized, not help seeking, but even within help seeking young people who are presenting to CAMHS, there's a significant delay before we pick up that psychosis might be the underlying problem and something that we can address. So in terms of an adolescent onset psychosis and the challenges of early recognition, we know that the emergence of psychotic experiences can be slow and often non-specific, so not directly pointing to core psychotic symptoms that are listed, are closely linked to developmental challenges. So again, if somebody starts to struggle at school or within their relationships or develops conduct issues, severe mental health may not be the first thing that people think of when considering what might be going on. They're often masked by characteristics of adolescence. So there's been quite a lot of work that also looks at the high level of prevalence in adolescent groups, particularly of unusual beliefs and quasi-psychotic experiences. So not all of these are indications of mental ill health, and it can be very difficult, particularly for community practitioners and primary care services to differentiate those. It can also often be seen as a source of growth and curiosity versus a source of distress and rupture. So we actually learned that a lot of young people adapt rather well to unusual experiences and can incorporate them in their wider experience without necessarily developing emotional distress or mental ill health. And I think we need to understand a bit better what that resilient group within that high-risk population leans on in order to remain resilient. We also know that there's a significant impact and changes on families and wider relationships, particularly peer networks. And again, it's not often picked up as a problem, but rather observed. So emerging difficulties and distress in relation to onset and relapse in psychosis only become apparent and clear from a perspective of a developed psychosis. So basically, when we look back, we can clearly see what a trajectory was. But if we're in there with a family or young person in that early phase, it might be very hard to differentiate from other possible manifestations, which can often lead to the wrong treatment being offered or treatment being delayed, which further then contributes to more negative outcomes. We also know that it's not just the experience of early psychosis, but it's often other factors that actually determine help seeking and why somebody might get in touch with their GP, speak to a guidance teacher, or seek mental health support. And it's often subjective distress and a number of contextual factors. So how well somebody might be supported in their community or by their school and so forth. We also know that there's a high level of individual vulnerability rooted in individuals' early experience. And we can start to see that a developmental model of early psychosis may be a helpful way to shine light on that. So we know that early attachment experiences and particularly early trauma and adversity can influence young people's appraisal of themselves and their circumstances, their ability to self-regulate negative and unwanted emotions, and generally their ability to cope. All of which are factors that can contribute not only to the onset of psychosis, but also its maintenance and might get in the way of somebody seeking and accepting appropriate help. Within at-risk mental states and early psychosis, we focus particularly on trying to understand interpersonal and social functioning as one of the key vulnerability factors that predict help seeking and poor outcomes. So not just the distress and onset of the disorder, but also how somebody might adapt to it or try and cope with it. We do know that particularly in adolescence, and we have observed this in several samples, social withdrawal, depression, and negative symptoms, so the kind of withdrawal from the world, a lack of motivation, abolition, lack of future planning, some cognitive impairments, and so forth, can be conceptualized as a response that develops early in psychosis, when shutting down allows the individual to cope better with something that may feel very overwhelming or aversive. So if somebody has multiple voices going on in their mind, it might just be easier to stay in their bedroom rather than to keep interacting with others and getting into situations that can be quite tricky. And that leads to a reliance on apathy, social isolation, a lack of drive and planning, which initially might be an adaptive way to cope with something that internally just feels very overwhelming, and reduce the impact of these experiences but it also then kind of creates a kind of vulnerability factor to recovery. So it's very hard to kind of switch off these safety behaviors and to become more adaptive to some of these experiences. We also know that a lot of the personal ways in which somebody makes sense of their own mental states and their internal experiences are happening in a social, are constructed and developing in a kind of social and interpersonal context. We know that the way others react towards us, the way, the level to which someone can be sympathetic and understanding in the face of what might seem like quite extreme experiences that we might not share is hugely determining how well somebody might be able to cope. So again, the social context and a kind of contextual understanding of that is really important in understanding recovery in early psychosis. So what that led us to is kind of a slightly more complex way of conceptualizing the kind of psychosocial model of psychosis by focusing on individual vulnerability, not only in terms of its biological, psychological, and social determinants, and then the pathways to the development of psychopathology or psychosis, which is in itself linked to future cause and outcome. But we also understand that each of these factors are interacting with each other. So even our biology and certainly social and psychological context very much grow and develop in the context of how we adapt to them. And it's a much more active interaction than we assume. We also know that this vulnerability is sensitive to both time. In terms of individual development, it does make a difference how this can be appraised. If somebody has a first experience of psychosis in their early 20s in the context of very established life circumstances versus an early adolescence, not really knowing what's going on. And it also depends on the cultural frame, both within the community and wider society. We know that stigma, acceptance of mental health difficulties play a huge role in individuals' ability to adapt. So when we look at adolescent psychosis from a recovery perspective, we want to go beyond the kind of essentialist view that kind of focuses very much on discrete presenting problems in terms of positive and negative symptoms as they present, but also a wider contextual view. So focusing on the distress and impact on day-to-day functioning rather than symptoms. Emphasize formulation as a process of narrative. So the meaning making and sense making for young people is crucial as part of a recovery journey. Focus on the engagement with services, not something that is very passive, but it's also sort of building that relationship and how we can work around that and develop pathways of help seeking that are basically sympathetic to an adolescent experience and status, and to explore and understand the interpersonal threats to recovery. So look at the wider social and emotional recovery. So I believe that effective relapse prevention equals emotional recovery from an experience of psychosis. And we need to spend time in that, understanding the individual onset. We know that interpersonal vulnerabilities play a particular role and also give us a kind of theoretical backdrop to understand better that transition in developmental terms. And we need to think about service engagement, not just something that happens from somebody who's help seeking, but also from a service and clinician perspective. So we're looking at that overlap of affect regulation, relapse prevention, and emotional recovery. I'm very aware that I'm pushing the limits of my time, but I'm going to carry on regardless for a little bit, if I may. So we, many moons ago, looked at a kind of follow-up study following people with an adolescent onset psychosis through our service. So this is a help-seeking population. And we looked at the PANS, which is one of the standard measures in psychosis. Nobody likes it particularly, but everybody uses it. But it differentiates it sort of positive symptoms from negative symptoms and more general levels of distress in terms of anxiety and depression. And we basically see that we do quite well in our services in achieving symptomatic recovery, particularly in terms of general symptoms and positive symptoms, less so for negative symptoms. But when we focus on the young people who manage to engage well with our services, or who we manage to engage well as services, we find that it makes very little difference in terms of positive and general symptoms of distress, that basically both those whose clinicians rate their engagement as less good, recover equally well. But we see that there's a real differentiation in terms of negative symptoms, that those who engage less well with services show clear preponderance for sort of developing a much higher level of negative symptoms. So again, service engagement is an essential part of thinking about recovery. We also had a more empirical look at those interpersonal vulnerability factors in the face of psychosis and found that there's a clear association between insecure attachment, social withdrawal, and psychosis. And we particularly found that those psychological mechanisms of being able to remain reflective and mentalize, so be able to imagine your own mental state and emotional state in yourself and that of others, as well as the ability to regulate negative and unwanted emotions, are clearly linked to insecure attachment, and in turn are linked to the development of negative symptoms, particularly social isolation and social withdrawal. When we look at kind of negative social and emotional recovery, and if we focus on psychological adaptation, so many quality of life type indicators rather than symptoms, we find that, again, that social cognition, that ability to mentalize an interpersonal vulnerability in terms of the strength of relationships, both developmentally and concurrently, act as the key mechanisms contributing to the development of social difficulties in this group. So again, we understand that there are key aspects in an adolescent onset psychosis that are developmentally rooted that can really get in the way of that positive social and emotional recovery. We also found a strong association between insecure attachment, interpersonal vulnerability, and psychotic experiences, or the persistence of psychosis, with lower quality of life and the development of negative symptoms, so that arrested recovery in social and emotional terms. Latterly, we became more interested to get away from traditional modes of assessment, and we're much more interested, okay, if there's something going on with how stressful, with how difficult young people with early onset psychosis find it to cope with the stresses in their environment, the social stresses and the demand stresses that they may have in school or other settings, and how much that might get in the way of their recovery. I think we need to understand much better what's actually going on a day-to-day life. And in recent years, we became very interested in experience sampling methodology. So rather than assessing young people every few weeks when they turn up in a clinic, or giving them questionnaires that ask them to reflect on the previous 2 weeks or previous week or whatever, we're using kind of app-based assessment methods that basically ping young people several times a day, checking in what they're up to and how they're feeling. So we're getting that direct relationship or a snapshot of daily life, how daily stresses, their ability to cope, and their experience of distress and symptoms interact on a day-to-day basis, in a hope to get a much clearer understanding of what might facilitate a clearer recovery. So experience sampling makes it possible to look at a person-context interaction when and where people are. So it's time sensitive and contextually related. So we looked at a number of factors in terms of particularly negative affect, levels of anxiety, assessing the context and emotional regulation, and we had very high compliance. So young people seem to quite like using their phone and their screens to kind of check in how they're doing. Largely what we find is when we compared young people, so controls, to a group of people with at-risk mental states and first episode psychosis, and we looked at daily stress, particularly social stresses, and negative affect, so the kind of things that kind of get in the way, like anxiety, feelings of loneliness, increased irritation, sadness, and feelings of guilt, we found that the control group, non-surprisingly, experienced much less negative affect compared to the early psychosis group. And that there's that the reaction or the negative interaction to event stress and social stress is significantly stronger in that group. So there's something to that interpersonal vulnerability that gets in the way of young people coping with these experiences. We then wanted to know whether actually feeding that back and actually using that day-to-day information to young people could be something that increases young people's awareness and reflective capacity to see what they're reacting towards, which aspects they find most difficult. So we carried out a small proof of concept study looking at social withdrawal and low mood in young people with at-risk mental states and first episode psychosis, and introducing a kind of interpersonal approach to support and treatment. We use the experience sampling app to also give daily feedback on how stressful and how they may have been feeling. So, their own data being reflected back to them, inviting a reflection of what may have felt particularly difficult, together with the variation in their experience of symptoms. We did this in a sort of mini randomized trial setting, and we found that treatment within an early intervention showed significant decrease in distress or negative symptoms with quite with a marked effect. And we also found that this type of intervention and the kind of reflecting of that kind of interaction between stresses and emotional reaction clearly led to some improvement in young people's ability to reflect on their own capacity to kind of adapt to these difficulties. So, to sum up, developmental vulnerability factors, particularly systemic and interpersonal aspects, have a significant impact on distress, help seeking, and engagement with services and recovery. And I think when we formulate the individual needs within an early intervention framework, we need to co-think around that, particularly when we focus on social and emotional recovery. We've shown that targeting vulnerability factors in our support and treatment can have significant impact on key factors of risk and resilience in how well young people adapt to the difficulty of having experienced early psychosis. And using ecologically situational assessments or experience sampling and direct feedback to engage clients in these assessments can improve treatment outcomes, engagement, and positive change in key mechanisms linked to emotional recovery. And we're currently starting to trial that in a kind of normative service context by making these tools available to both patients and clinicians to use actively in treatment. So we feel that our work highlights the essential importance of a social and emotional recovery approach within an early intervention framework, facilitated by a focus on systemic and interpersonal factors and interventions over and above what we do quite well in terms of symptomatic recovery, focusing on a constructive adaptation to psychosis rather than waiting for symptomatic experience to go away to facilitate recovery, and to use a dedicated early intervention approach that can be informed by a developmental model of adolescent onset psychosis and recovery. And I think I'll end here. So I'll stop sharing and thank you.
Hi, Matthias. Thank you. That was
Hi,
brilliant.
Susie.
Nice to see you. Brilliant. We have
I'm
a couple
still
of...
not getting used to just talking to a screen rather than to people. I'm so sorry.
No, it was a very good, a real whistle-stop tour of all the developmental literature. So really helpful. Thank you. It looks like, I mean, I guess my question at the end there was, it looks like we've got some local Scottish data evidencing better outcomes for young people in EIP services. And I think that's really helpful to hear, because we know that the service model is effective when it comes to RCTs internationally, but I think it's helpful to understand the local context as well. And actually what we're seeing is that services that are attuned to the developmental stage and the social difficulties that the young person is presenting with are more likely to make long-term outcomes improved. And that's really helpful to hear.
Yeah, and we've been quite fortunate. So obviously Lothian had a sort of adolescent onset early intervention service. And because of some CSO funding and subsequent funding and a couple of PhDs, we actually managed to get, almost 8 years of continuous follow-up data of people attending. We don't have a very systematic comparison with CMHT or adult services, because there's obviously other characteristics that get in the way. It's not a straight one-on-one comparison, but certainly within that population, we see recovery rates and outcomes that are on par with, as you say, the kind of RCT-based early intervention and frameworks. Unfortunately, the service turned into a more integrated service, and I think we struggle a bit to kind of keep hold of that early psychosis pathways and actually retain some of the elements that we demonstrated are most effectively involved in positive outcomes. So it's certainly a discussion to be continued.
Yeah, no, that's really helpful, because I do think one of the disadvantages of pathway type approaches is that clinicians get pulled into other things and their time isn't ring fenced. So that's really, really helpful for us to hear. We have a few questions, and I wonder if we should pick up some of these questions.
Yeah. Thanks a lot, Matthias, for that. That was really good. I have 3 questions here. So the first question is, are negative symptoms not a core component of psychosis, particularly in adolescents, rather than a secondary compensation? So that's the first question.
Yeah, and again, it's how you look at it from a, particularly from a retrospective perspective. So clearly, positive and negative symptoms are core components of how we understand psychosis and recovery. But we also know that I think the kind of more negative symptom outcome, if you want, like the social withdrawal, the kind of is linked to these kind of contextual adaptations. So it's something that can be avoided. And it's a bit of a chicken and egg situation. So we do see that in young people who have a slightly better recovery journey, we see less emergence of negative symptoms. And of course, you could say that, well, not everybody's psychosis is different, and they may just have the characteristics biologically or otherwise to have a propensity for. But we also know if we actually focus our interventions on these aspects, we can see changes within that. So I'm not convinced that it's quite as deterministic as it sometimes seems. And I do think that the propensity of seeing poor negative symptom outcomes in a less adolescent onset is what I said earlier, that it really kicks people's individual development in the shins. If you can't finish school, if you don't get access to college, if you can't establish an independent relationship, and if you get stuck with your parents into your mid-20s in an unhelpful way rather than a desirable way, then that will contribute to your negative symptom development. So I'm not sure it's quite as unidirectional and linear as it sometimes seems.
There's a next question I'll take on from there, which is very relevant to particularly the data that you just presented. Are there studies that you could guide me to that consider the impact of the role of the caregiver, like a parent, in supporting recovery for young people? I believe a parent's role to be vital in recovery, and does this app allow for that? That's the question. I know that as an early intervention service within our service, we have a very high focus on family involvement, and we do quite a bit of family interventions as well, behavioral family therapy and stuff. So I'll leave that question to you, Matthias.
Yeah, so absolutely, and also within our service model, working actively with families, offering family support as well as young people and involving other carers in that. I think we often forget about peers. I think we can focus more on peers because they play a major role in actually supporting young people, returning to anyway. So yeah, absolutely important, and I think that I wouldn't underestimate that, and I think any service model needs to include that. At the moment, we're trialing this by giving young people and clinicians access to the data and using that in treatment and for treatment planning. And clinicians actually see a graph of how the week was when they think about setting their goals, and they see how young people feel their goals are going, not just when they're turning up for their fortnightly appointment, but also then from a day-to-day basis. Young people are free to share that, and they can actually produce sort of graphs of how they're doing with whomever they want. And there's certainly the facility to share that with families who are actively involved in treatment. So if families attend for behavioral family work and so forth, then that could be part and parcel of it. In our current trial, we're not doing that systematically, but the facility is there.
Thanks, Matthias. There's one more question, but I think I'll ask that after the next talk.
Okay, yeah, sorry. I know I went over. I'm sorry. I'll
pass on to Alastair. Thanks. Thanks, Matthias.
Thanks. It's fascinating, and I'm sure we could go. We could go on, but let's hear from Ian, and then we'll have a bit of time, I think, to have a more general question and answer session towards the end. So I'm going to introduce Professor Ian Kelleher, who's Chair of Child and Adolescent Psychiatry at the University of Edinburgh, consultant psychiatrist working in specialist child and adolescent mental health services, and Scotland's first Academy of Medical Sciences professor. Ian's published more than 100 scientific papers on psychosis and is listed by Expertscape as one of the world's most highly cited researchers in the field. He leads an interdisciplinary research team that takes a data-driven approach to identifying young people at risk of psychosis. The goal of this research is to improve psychosis prediction and ultimately prevention. So Ian, dying to hear from you.
Okay, thank you, Alastair. Good morning, everyone. I'm just going to get this up and working. Okay, Alastair, can you hear me? Can you give me a thumbs up if you can hear me? Okay, great, thanks.
Very clearly.
Okay.
Yeah,
great. Okay, so I'm going to talk a bit about assessment, diagnosis, and treatment of psychosis in children and adolescents. I'm going to take a very developmentally focused approach to this. And as you see, most of the research in psychosis has been focused on adults and adult psychiatry and adult mental health services. And I'll talk a bit about what we know specifically for children and adolescents. And no conflicts of interest to disclose. So I'll talk about early onset psychosis, so treatment, assessment, diagnosis, and treatment, identification of psychosis risk, and just finish up talking a bit about what I see as future directions for the field. So I thought I might start by mentioning about, how relevant is psychosis to CAMHS? And I think there are a lot of different views. Personally, I was often asked during my training, why did you go into child adolescent psychiatry? You're interested in psychosis. And I hope by the end of this presentation, you'll see why psychosis is really important to CAMHS. So early onset psychosis is just a term for psychosis that's diagnosed under 18 years old. So that is all of the psychosis that we see in CAMHS. And it's estimated that about 10% of psychosis cases are diagnosed in CAMHS, the rest being diagnosed in specialist adult mental health services. So they're a small proportion of total cases. But early onset psychosis is associated with more severe symptoms, poorer functioning. This is relative to adult psychosis, more hospitalizations, longer hospitalizations, and poorer outcomes from a social and occupational perspective. And so from that perspective, I think it's pretty clear why early onset psychosis should get particular priority when it comes to receiving specialist early intervention and psychosis services. So there are a number of factors that I think make early onset psychosis that bit more challenging than adult onset psychosis. One of the factors that Matthias mentioned or alluded to as well was that mental disorder diagnoses in childhood and adolescence are a moving target, as has been put, and that's because young people's brains, their social development is all happening at a very rapid pace, and so that's all unfolding at that time, and so you see a lot of changes around that time too. One of the challenges is that in many cases of early onset psychosis, there is also autism, and there are some overlaps in symptoms that can make the diagnosis a little bit harder to come to. Having some kind of brief or attenuated psychotic symptoms are common in young people who come to CAMHS, which adds to the complexity of diagnosing psychotic disorders. And that really highlights the importance of having not just psychosis expertise, but also developmental expertise, which is what is the case in CAMHS. And always remembering this, this picture I put up, and I'll put up at several stages, but remembering that children and adolescents are not small adults. They need their own developmentally informed evidence base. So how do we get better at identifying psychosis in adolescents? Matthias also mentioned that that cases can be missed within CAMHS, and of course that that could happen in any service. So how do we improve on that? How do we make sure we're missing fewer cases or assessing them closely enough to not let that happen? So I think the first point is consider psychosis as a possibility. And that might seem a little tongue-in-cheek, but it's not at all, because I think sometimes we really don't consider it as a possibility in CAMHS, and it's really important that we do. Use a structured or semi-structured instrument to assess psychotic symptoms. You know, they're challenging symptoms to assess. There can be a lot of change over time, and ensuring that you're having some specific standard as to how you're assessing them, something that you can look back on in your notes and see how they've changed over time, is really important and valuable. And there are a number of instruments that you can use for that. There's the comprehensive assessment of at-risk mental states, and that's the interview that came from Australia, from Melbourne's research on early intervention of psychosis, clinical high risk. Then the American version, the structured interview for psychosis risk syndromes, SIPS. There's also the Kitty SALS, which many of you will be familiar with. It has a psychosis section that you can use to give some structure to your assessment. And the Socrates is what I typically use in my clinical practice. It's not so much an instrument, but a mnemonic, and I'll speak a little bit more about that. But about, you know, what are the core things you want to assess when somebody has psychotic symptoms? What do you want to assess and document? Another key factor is to resist diagnostic overshadowing. So autism is the great diagnostic overshadower. And it's important to remember that up to 10% of individuals with autism go on to develop psychosis at some stage. And up to 50% of early onset psychosis occurs in young people who have autism. And so you know, when I'm asked to see a young person with a query around whether they have psychosis, I'm often told, but they have autism. And I always say, well, and they have autism. So it's important not to frame autism as somebody being exclusionary for a diagnosis of psychosis. And that often happens. So it's an important factor to take into account, but certainly doesn't exclude the possibility of psychosis. So putting some structure on your assessment. So this is the typical structure that I use, that I go through in my head when I'm assessing the young person, because it's reminding me of some of the key features that I want to touch on, to get some information on, and to document. And so Socrates is a mnemonic. You know, many of you know from medicine as a pain mnemonic. It can serve as a mnemonic for us too. So this is for hallucinations, but if you leave out the S, then all the same still applies to unusual thought content as well. So the S is about source, so internal and external space, the onset, duration, and frequency of the symptoms, character and context. And so I'll run through just one example so you can see, but if you're interested to learn a bit more about that, the easiest way to find it is on the Royal College of Surgeons in Ireland website. So if you go to repository.rcsi.com or just search RCSI repository, and then in the repository search Socrates, will bring up a manuscript about the Socrates. So this is an example of a young person I saw in CAMHS who was asked to see about a query around psychosis. And she told me that she was experiencing these unusual perceptual experiences, that she was hearing something, and she described it as being about half the time she hears it and it sounds like it's in her head, but half the time she hears it, it sounds like it's outside of her head. It started 2 months ago. It built up within days, from unformed murmurs or whispers to becoming formed words and sentences. It happens dozens of times every day now, and it lasts for seconds to minutes at a time. The longest ever duration has been about 30 minutes. She describes the voice as young male voice that sounds the same age as her, speaks in a similar accent, but doesn't recognize the specific voice, doesn't think it's the voice of somebody that she knows. Has built an image of him in, I can't remember actually if this was him or her mind, but has never seen him, so hasn't had any unusual visual experiences. What's the content of these? So, you know, when the person speaks, what are they saying? So this person said that the voice talks to them directly, no third person or commenting, always derogatory comments like you're worthless, they're all laughing at you, some commands like you should kill yourself. He talks back to the voice sometimes, but only when the voice, but only when alone. And again, that's kind of a measure of their level of functioning. So only when alone, but the voice does not respond to what he says. So not engaging in actual conversation. Reality testing and attribution. So a key part that is sometimes missing from the notes. Is to, you know, once you've had a discussion about it, ask the person about their attribution and what's going on. When this happens, what do you think is going on? And this young person spoke in detail about this. I don't know. Eventually said, I think someone might be watching me or messing with me. Just who? And the young person said, I don't know. And what I would typically do, and what the recommendations for those structured instruments is try to let the young person come to a conclusion themselves about spontaneously giving their attribution for it. But if they don't give you an attribution ultimately, you will have to ask about it directly. So something like, do you think it's definitely someone watching you, or do you ever feel like it could be your mind playing tricks on you? And I think it's important as well, that people can have affirmation biases, they'll say yes. So it's important not just to say, do you think it's definitely someone watching you, and leave it at that, or just say, do you think your mind playing tricks on you? It's to give them both choices so they can give an answer one way or the other that isn't just yes. And so this person said, well, sometimes it feels almost real, but I know it can't be. So in this young person, there is at least some degree of intact reality testing still. And the timing, so it's more likely when this young person is alone. It's not in the context of alcohol or substance use. It's not in the context of physical illness. And it's not in the context of being hypnopompic, Some are trying to assess how it's affecting their functioning. So that can be things from, does the person talk back to them? Do they do that even in front of other people? But no, not in front of other people, but yes, sometimes when alone. And when it comes to hearing some command sentences, well, this young person unfortunately doesn't feel compelled to act on what they say. And is it distressing? Well, quite clearly. And how severely do they rate their distress? So this young person rated as 10 out of 10 at worst. So that's the most severe level of distress. And they're really, really distressed by these symptoms. I'm going to talk a bit about the evidence-based for treatment of early onset psychosis. I'm going to talk about medication and then speak a bit about psychosocial interventions. Again, I'm talking about specifically for children and adolescents. So not surprisingly, there have been far fewer medication trials in children and adolescents than there have been in adults. But there are clinical trials for all of these medications, specifically in children and adolescents. So what are the results of them? So this is a helpful umbrella review of medication trials for children and adolescents with psychosis. And so what they found was that ziprasidone was not more effective than placebo, but all the other medications on the screen were more effective than placebo. The ones you see in green, asenapine, paliperidone, quetiapine, aripiprazole, and rasidone had a small effect size benefit compared to placebo. Risperidone and olanzapine had a large effect size benefit compared to placebo. And in terms of tolerability, so olanzapine and paliperidone stood out as being poorly tolerable compared to placebo and compared to the other medications when they're compared to placebos. I want to mention, I guess, olanzapine specifically because it is an effective medication, but our national clinical program in Ireland is that olanzapine should only be considered second line, and I definitely agree with that. I think olanzapine should everywhere only be considered at least second line. And the truth is, I try to avoid it altogether because of the poor metabolic side effects. And I think that is a principle that many of us try to adhere to, but often we use olanzapine and maybe intend it to be short term. And I would say if I had £1 for every time I've heard, well, I intended it to be short term only, but then they ended up staying on it, then I'd have a lot of pounds. My overall advice with olanzapine is that if you don't intend somebody to be on it long term, just don't start it. And of course, I never say never. Nothing's entirely black and white. There are some very specific situations where I might consider the use of olanzapine in a young person, but they're a very small number of cases, and I really try to avoid it because, as I said, of the cardiometabolic side effects that come with it. What about clozapine? What about clozapine specifically in relation to children and adolescents? So the good news is that has also been trialed in children and adolescents. And the results from that are that clozapine is significantly more effective than all other analyzed antipsychotics that have been trialed in children and adolescents. It has a large effect size benefit and a large improved benefit, even compared to olanzapine. So does clozapine work for children and adolescents? The answer is yes, it does. What about long-acting injectables? So here is a helpful review article about long-acting injectables. And the overall conclusion from existing evidence is that they may improve clinical outcomes in adolescents. However, existing reports have substantial methodological limitations and further research is needed to guide the use of LAIs in children and adolescents. So I guess the jury is still out on LAIs. One medication that I want to mention is amisulpride. So that wasn't on the list of that I previously showed you because there have been no trials in adolescents of amisulpride. And that's something I hope we can change, but this is a systematic review of the use of all of 32 oral antipsychotics. So much larger number because it was on adults, and many more oral antipsychotics have been trialed of all oral antipsychotics for the treatment of adults with schizophrenia. And what you can see in these two graphs is up at the top, you see the overall change. So you see the overall change in symptoms. What has the biggest effect in terms of overall change in symptoms? Well, it's clozapine there. But the next one you see is actually amisulpride. And this is positive symptoms over here specifically, and actually you see amisulpride right here at the top. So there's a particular study that I want to mention called the Optimize study, which I wasn't involved in, but I think it's a really important study on schizophrenia and schizophreniform disorder. And so it didn't include under 18s, unfortunately, but it included people from age 18 up to 40 years old. And this was a study to look at the use of amisulpride compared to olanzapine. And the approach of this trial was that everyone who entered the trial was initially treated with amisulpride, open label, so they knew what they were getting for 4 weeks. And even the first evidence, I think, is particularly impressive. So what they found was that 67% of individuals went into remission just in the first 6 weeks of being treated with amisulpride. And I think that's a lot higher than a lot of us expect and a lot of people's clinical experience. And I think that's, you know, showing that amisulpride is a very effective medication for the treatment of psychosis. What do they do next? So if you were not in remission, the second step was blinded. So you either were assigned randomly to continue to receive amisulpride or to be switched to olanzapine, which many people would consider the best medication besides clozapine for the treatment of psychosis. And what do they find when they follow them up? So that in the amisulpride arm, another 45% went into remission, and the olanzapine arm, the same number went into remission. So there was no benefit of switching to olanzapine. Just as many people went into remission if they stayed in amisulpride as if they were switched over to olanzapine. But I think one of the key things to take away with that is that the amisulpride weight gain was half that of olanzapine. So again, coming back to metabolic side effects, it has a much better metabolic side effect profile and just as effective. So as I said, unfortunately, at the moment, there are no pediatric studies. I hope that's something we can change. And amisulpride, if you look at the summary product characteristics, it's contraindicated under 15s. It's an unusual choice of term. I spoke with the medicines regulator about why it was contraindicated. It's unusual to use that term unless there was a trial and there were poor outcomes. There have been no trials, and they told me it was because there's a lack of safety data in children and adolescents. Usually when that's the case, you say something is not recommended rather than that it's contraindicated, but that is the wording that they've used. And so it's your hands are tied with regard to using that in under 15s, in my opinion. But what it says in relation to the use in 15 to 18-year-olds, it should not be used in adolescents until further data are available. And of course, for doctors and nurses in the audience, you'd be well used to seeing that for pediatric medicines in general. So I just wanted to make the point that you can say that for any of these antipsychotics, essentially, and indeed many of the pediatric medications outside of antipsychotics. So similarly, olanzapine is not recommended for use in children and adolescents below age 18. Risperidone is not recommended for children below age 18, and aripiprazole is not recommended for young people below 15. Of course, we have to be pragmatic and use the available trial data to guide our treatments. I want to speak briefly about adverse effects, something that I often get asked about. So children and adolescents are at higher risk of adverse effects from medication treatment. So higher risk of metabolic effects, including dyslipidemia and weight gain. There's a higher risk of prolactin elevation, and a higher risk of being sedated. What do you do about metabolic side effects? So there is some evidence base for involving dietetics, for involving exercise physiotherapy, and one that I'm sometimes asked about is metformin. So I just have a slide in here just because, again, it's something that colleagues sometimes asked me about the use of metformin in young people who are being treated with antipsychotic medication. So metformin is a biguanide medication with 3 known mechanisms of action. It decreases gluconeogenesis and improves insulin sensitivity, and it slows intestinal absorption of glucose. Sometimes people worry about causing hypoglycemia. Well, metformin does not stimulate insulin release. It acts only in the presence of endogenous insulin, so it's very unlikely that you could cause hypoglycemia with metformin. What are the findings though? If you use metformin in somebody who's using antipsychotics, how does it affect their weight gain and weight loss? So there's a modest weight loss associated with it. So it's certainly not a silver bullet or a magic pill for addressing metabolic side effects of antipsychotics. It's modest. It may be better at preventing weight gain, and that's why it's really important at the early stages of somebody starting antipsychotics to monitor the trajectory of the weight gain, not wait until somebody has gained huge amounts of weight. But if you stop it, the weight is regained, so it only works as long as you use it. So something reassuring from the summary of product characteristics, as opposed to many of the medications that we use in CAMHS, is that metformin tablets can be used in children from 10 years of age and in adolescents. The usual starting dose is 1 tablet of 500 milligrams or 850 once daily, given during or after meals, and the max recommended dose is 2 grams daily, taken as 2 or 3 divided doses. You should check someone's renal function before treatment and regularly thereafter. But I think the key thing for me here is that, you know, metformin is not going to make up for the metabolic side effects of olanzapine, and so avoiding olanzapine where you can. Another thing that I'm frequently asked about is advice on switching antipsychotics. That or somebody may be thinking now, well, actually, yeah, I've had somebody who's on olanzapine for a long time. Could I switch them? Could I try something different? And not sure what the best approach to do that is. So this is a tool that I use. I find really helpful. NPS medicine-wise, if you put that into Google, NPS medicine-wise Australian prescriber, they have an antipsychotic switching tool that will give you some guidelines about how you switch from one to the other. So that can be a helpful thing to have. Okay, I'm just going to speak briefly then about psychosocial treatments for early onset psychosis. So what's the evidence base? So lots of different psychosocial treatments have been trialed in psychosis. Again, what you'll see, the same as with the medication, the list is a lot shorter if you look at what's been tried in children and adolescents specifically versus what's been used in adults. So I'm just going to put up this quite recent review, which is based on a Cochrane systematic review of psychological interventions for children and adolescents. So what did they conclude about the evidence base for psychological interventions for adolescents? Some psychological interventions may have some beneficial effects in the treatment of adolescents with psychosis, but the evidence is of low or very low certainty. Scientific support for efficacy and effectiveness of psychological treatments for adolescents with schizophrenia is virtually missing. And so that's really disappointing for our field, that we're so reliant on trying to interpolate adult findings, and actually it's very clear that we need developmentally informed findings, and that's really lacking at the moment. And again, something I hope we can make some progress on over the coming years, having a specific evidence base for children and adolescents. So you might say, well, if it seems effective in adults, it'll probably be effective in children and adolescents. And that's where I bring up this picture again of reminding us that maxim, that children are not mini adults, and so please don't make that assumption that just because something works for adults, it should also work for children and adolescents. And I'm going to give you two examples here from the very limited field of psychosocial interventions tested specifically in adolescents with psychosis. And so family therapy is a key part of the early intervention and psychosis program for adults with psychosis. But what is the evidence base for children and adolescents? And it's really just completely lacking, which is particularly poor when you consider that children are almost certainly living at home with their parents, with their family, and so there's potential to be particularly important, but we have a real lack of evidence there. This is one study that was published a few years back in JCAT, family-focused treatment for adolescents even at a high risk for psychosis. So they didn't actually have psychosis. This is the high-risk approach that Matthias also spoke about earlier. So, and it was a randomized controlled trial, which is great to see. I hope we can see many more of these for adolescents with psychosis or at risk of psychosis. It involved delivering 18 sessions of family therapy compared to 3 sessions of family psychoeducation. And so that was this family psychoeducation was considered an active control. And what did they find? Well, so they found that overall family therapy was superior to family psychoeducation, but they went on to divide the group into 3 age groups to see, well, is this true across the developmental range? Is it true across that spectrum from childhood into adolescence and early adulthood? And actually, these are the groups that they had: 12 to 15-year-olds, 16 to 19-year-olds as their adolescent group, and 20+ years for our young adults. And what they found was that the effect for family therapy was driven by the age 20+ group. And actually what they found for the 12 to 15-year-olds was that there was no difference between getting 18 sessions of family therapy versus just 3 sessions of family psychoeducation. And importantly, what they found for the adolescents, 16 to 19-year-olds, was that the outcomes were better with the brief family psychoeducation than with the in-depth family therapy. What about CBT for psychosis by comparison? So to my knowledge, there has still been no randomized clinical trials of CBT for psychosis in children and adolescents, which again is a big gap in the literature. But there is this helpful study that tried to look at could there be developmental differences. And this is back from 2006, looking at the age and outcome associated with using CBTP. And again, they had an active control, which was supportive counselling, and they compared that also to treatment as usual. And in this group, they divided them into young adults, which was 21+ or under 21 as they're younger. So from 21 to, I think it was to 18, but maybe 16. And what was interesting was, bearing in mind this is secondary analysis, but they found that there was a positive effect of CBTP for individuals who were aged 21 years old or more. But what they found when they looked at the under 21-year-olds was that supportive counselling was superior to both CBTP and treatment as usual at 3-month follow-up. And what they reported was that, these are secondary analyses. I don't think any of us can see this as in any way definitive, but the authors made the point that the differences were consistent over a number of methods of assessment, adding validity to the findings, and robust even when differences in sample characteristics, shorter duration of untreated psychosis, and worse symptoms at baseline the young group were controlled for. And so, I think that just really highlights again the importance of having a specific developmentally informed evidence base. So some kind of interim conclusions before we move on to risk for psychosis, but I hope it's come across loud and clear the importance of remembering that children and adolescents are not small adults. They need developmental expertise in the assessment, diagnosis, and treatment of early onset psychosis. And that children and adolescents deserve a robust, evidence-based, developmentally informed treatment. And I think, we have a duty, those sort of child and adolescent clinicians, to advocate for that. The pharmacological treatment, there are fewer studies than in adults, but overall evidence supports efficacy of antipsychotics, significant variation in efficacy between different antipsychotics. Some antipsychotics have no trials in children and adolescents, and there are more adverse effects, and those need careful, again, developmentally informed management. And the principle of starting low and going slow with children and adolescents, one of the benefits often is that, they're usually at home with parents, they have a lot more support than adults might, and hopefully that gives us an opportunity to go slower in our uptitration of medication, as might be the case. Psychosocial treatments, there's very little evidence specific to children and adolescents, but the limited evidence base suggests that there might be important differences to adults, and we need more research specific to children and adolescents. So I'd like to talk a bit about psychosis prediction and prevention, and where we are with that. So again, Matthias helpfully has already spoken a bit about clinical high-risk approaches. Ultra-high-risk and at-risk mental state are essentially, equivalent terms. So it's for identifying people who are at elevated risk of psychosis before they actually meet formal criteria for a psychotic disorder. So there's three groups within the clinical high risk approach. There's people with attenuated psychotic symptoms, for people who are briefly psychotic, that's the second one, and then there's people who have genetic risk and functional deterioration, that's the third one. But I'm just going to speak really about attenuated psychotic symptoms group, because that's the large majority of clinical high risk. It's 90% of the cases. So we use structured instruments like the interview for psychosis risk syndrome in America, or the CAMHS in Australia, to assess threshold and subthreshold psychotic symptoms. And many of you will have been trained in using this here, especially when Alice and Young came from Melbourne to Manchester for a period of time. And the 3-year follow-up meta-analysis suggests that about 25% of individuals who meet these criteria are diagnosed with psychosis. But it's important to note that that transition rate has been declining over time. Again, we went a long time without, meta-analyzing these for children and adolescents specifically, but this is work with which Ulla Long and my group led a systematic review specifically for children and adolescents. And what she found was that the 1-year risk of psychosis in children and adolescents diagnosed with a clinical high risk syndrome was 10%, 2 years was 12%, and 5 years was 16 plus. 5 years plus was 16%. So again, there's a difference to adults. The risk of psychosis was not quite as high, but very elevated compared to the general population. Those still are very high rates of risk for developing psychosis. But there's a little bit of a fly in the ointment that's been highlighted recently. So, and that is that recent research has shown that only a very small proportion of all psychosis cases are identified using the clinical high risk approach. So the first paper there is from Maudsley and Institute of Psychiatry Centre in London, which looked at what proportion of all psychosis cases were captured using the clinical high risk approach in their service, and they have a long-running free to access world-leading service. And they found it was extremely small. Only 4% of psychosis cases were captured using that approach. And the second paper came out very recently. This is from Melbourne, from the group that led the clinical high risk approach development. And they found that even at the home of clinical high risk services, where of course they have excellent clinical high risk services, it was 14% of cases. So that means that 86 to 96% of cases are not identified, even at leading academic medical centres. And this is a quote directly from the second paper from Melbourne, who acknowledge themselves that other methods are needed to identify those at risk for psychotic disorder. And so that's something that in my research group we've been working on over the last number of years. How do we increase proportions of individuals we identify who are at risk of psychosis? Because of course that would open up the possibility of prevention, which is what we would love to see. I'm going to speak briefly about that. So this is the data-driven research that we do in my research group, and this was the particular study I'm going to mention here was using fantastic healthcare registered data sets that they have in Finland. So some of the Nordic countries are famous for having excellent healthcare registers. There are also excellent healthcare registers here in Scotland, and that's what I hope to leverage here as well. So this is based on everyone born in Finland in 1987, who we were able to follow up to age 28 using their National Institute for Health and Welfare records. We were able to tie together multiple records on these individuals to see were there opportunities to identify risk for psychosis earlier in life. And we've looked at a number of risk systems, as we call them, or healthcare or population systems that might capture that risk, including coming to the emergency department for self-harm, including having problems in school. But I'm going to focus today on what I think is the most important promising of them, which is our specialist child and adolescent mental health services. So, psychosis is uncommon in CAMHS. As we discussed, about 90% are diagnosed in adult mental health services. And I think there has been a perception that the reasons for presenting to CAMHS differ a lot to the reasons for presenting typically to adult mental health services. So, here are some of the problems we talk a lot about in CAMHS. We talk about problems with attention, concentration, impulsivity, social communication problems, peer difficulties, learning problems, language problems, sensory sensitivities, motor coordination problems. And certainly I think those are things that get less attention in adult mental health services, and that can make us seem like we're doing very different things. But something that always struck me was, all of these things are risk factors for psychosis. And so my question always was, well, what if we could follow the young people who come to see us in CAMHS over time? Sure, not many of them have psychosis now, but would many of them have psychosis if we could follow them into adulthood? And not just a general abstract question, but what kind of percentage are we talking about? What would be the risk of psychosis in this group, and what proportion of psychosis cases could potentially be captured in CAMHS? And that's been a really difficult question to answer, because to answer that kind of question, you need to have huge studies that follow people for very long periods of time, and that's just really it's just not feasible. But had it become feasible with the coming of age of the small number of countries that have these healthcare registers that allow us to follow whole populations over very long periods of time. And it's especially important when you look at, in populations that are difficult to reach, and that often includes people who come to child and adolescent mental health services. It's difficult to keep people coming back to research studies, to engage them over time. Well, one of the real fantastic things about the registers is everyone is captured there, and you can get information on everyone. That doesn't require active participation. So this is the paper that I'm going to mention the results from. As I said, it's everyone born in Finland in 1987. Followed over time, we were able to identify everyone who went to CAMHS during their childhood and adolescence. We were able to identify if you'd gone to CAMHS as an outpatient, if you'd ever been admitted to an inpatient CAMHS unit, and we were able to follow them up to age 28 and see what proportion were diagnosed with psychosis, and then tie that back to their records on coming to CAMHS. And so as a point of comparison, so here is the meta-analytic figures for your risk of psychosis if you're diagnosed with a clinical high-risk syndrome. So what about if you'd come to CAMHS? What is your risk when you're followed up over time of being diagnosed with a psychotic disorder? And so what we found was that if you came to CAMHS, 13% of that group by age 28 were diagnosed with a psychotic disorder. If you come to CAMHS in adolescence, so from age 13 up to 18, that was 15% of individuals. And what if you've been admitted to an inpatient CAMHS unit? What does that tell us about you? Well, 24%, so a quarter of that group were diagnosed with psychosis by age 28. And if you were admitted to CAMHS as an adolescent, so between 13 up to age 18, 37% of that group were diagnosed with a psychotic disorder by the time they were 28. So just knowing some very simple administrative health data, just knowing that they came to CAMHS tells you as much about their level of risk for psychosis as this detailed clinical high-risk assessment, the outcome of that. But what about the flip side? So the question about what proportion of cases come to CAMHS. So we know, okay, so this is the proportion who want to develop psychosis, but of all psychosis cases, what proportion had come to CAMHS? Because that will tell us about the potential for prediction and also prevention in CAMHS if we have preventive interventions. So up at the top quarter, you can see here, so again, the two studies I mentioned earlier, the first one is from the Institute of Psychiatry, the Maudsley Centre in London, and the second one is from Melbourne, the home of clinical high-risk services. So it's 4% to 14% of cases were captured in those services. So a very small proportion. What about in CAMHS? What proportion of all psychosis cases had at some stage in their childhood come to CAMHS for some reason? And it was 50%. So a full 50% of all psychosis cases diagnosed by age 28 were in people who had come to CAMHS at some stage in their childhood. So what does that mean? Well, it means that there are enormous opportunities for the prediction and ultimately prevention of psychosis within CAMHS services, far higher than I think any of us would have predicted without the data. So, what are the things that we can conclude from that? Well, children and adolescents who attend CAMHS are a high-risk group for later psychosis. So it's not just about the psychosis that they may be diagnosed with at CAMHS, it's about actually their trajectories over time, especially those who attend as adolescents and especially those who have an inpatient psychiatric admission in adolescence. It's important to bear in mind that this is about systems and not about childhood mental disorders per se. So remembering that most young people with childhood mental disorders don't come to CAMHS, most don't present to mental health services at all. Some will go to primary care or other mental health services. This is about the system, and the risk is in people who came to CAMHS. And it's not related to a specific diagnosis. We saw increased risk across the diagnosis spectrum. But an interesting case in point was that even young people who came to CAMHS who didn't have any diagnosis, they had a similar level of risk of developing psychosis as young people who did develop, who did have a diagnosis in CAMHS. So what are the implications? Well, I think it really puts a spotlight on CAMHS and the potential within CAMHS for identifying risk and advancing early intervention and actually prevention for psychosis. So just to finish up, I'd like to just finish with this video. It's a very short video that we made about some of those findings. Okay, so that paper just came out in the past number of months. So just to finish up, so overall conclusions: children are not mini adults. The assessment, diagnosis, and treatment of psychosis in children and adolescents should be developmentally informed, and that we don't just extrapolate from adult data. More research is needed on psychosis treatment in children and adolescents. We've seen a particular lack of randomized clinical trials for psychosocial interventions that I hope we can change in the years ahead. And that really excitingly, I think that CAMHS provides this enormous opportunity for the prediction and ultimately prevention of psychosis. And again, this research that we're going to be doing here in Edinburgh, focusing on that. So more data-driven research identify those within CAMHS who are greatest risk. We're doing research looking at causal inference methods to understand what might prevent the development of psychosis, and clinical research specifically on children and adolescents for interventions in first episode psychosis. I'd like to thank some of the researchers who contributed to the data I presented here and the funders. Thank you very much.
Yeah. Take the camera. Hi, Ian. Thank you. That was very interesting. And it's really interesting and helpful for us to just have an update, I think, on the CAMHS literature and evidence. I think we often at STEAM find that we're picking up people with early psychosis who've maybe been sitting on a tier 3 CAMHS waiting list for a year, and they have a long DUP. And I suppose I just wondered if you maybe had any messages for us in terms of our interface with CAMHS. It's something that we've always struggled with a little bit, because we have, I think, 5 CAMHS teams in Glasgow. We have a forensic team, and we also have an inpatient unit. But there's a lot of variation in practice across those teams, and really mixed experience of kind of picking up early psychosis. And just, well, you know yourself, if people have had a long DUP, by the time they get to us, there's a lot of sort of disability created as a result of that. And I just wondered if you had any messages for us in terms of our interfaces with the CAMHS teams in Glasgow.
Yeah, I mean, I guess one of the things I can say about that is that, you know, I mean, psychosis has been a very academic, research-informed area in mental health research for a long time, you know, and many of the adult psychiatrists working in research, psychosis is a really big area. And so it's a really big focus, I guess, of training in people coming through that to mental health services, and a really big focus of research. And unfortunately, that just hasn't been the case for child and adolescent psychiatry and child and adolescent mental health services. So that's something that I hope we can change, especially when we're kind of showing these results and saying, actually, this is a huge issue. It's not even just the numbers of psychosis cases, it's the numbers of future psychosis cases is enormous. And I suppose I think it's going to take some culture change, but I think it also reflects that, you know, an underinvestment in academic leadership in mental health services in general, in Scotland and the UK. The same I could say is true for Ireland, just as equal. There are very few professorships in child and adolescent psychiatry. There are 2 in Scotland. And so, you know, there are multiple adult psychiatrists who are professors in with special interest in psychosis. And I suppose that's, you know, I think the movement for EIP, it's no coincidence that has gone better or more smoothly, I guess, for adult psychiatry. And I think part of it is starting to see that it is a really important issue for us in CAMHS, not just for adult mental health services. So I hope we can start to change that culture.
Ian, can I request that you stop sharing the slides, if that's okay, so I can see you also.
Oh, sorry. Okay. Let me see.
Thank you. We have. Oh, perfect. We have some more questions for you specifically. I think mostly I'll take a few from the chat. Have you come across the probabilistic or actuarial approach to spotting depression more likely to be bipolar depression? Any thoughts?
I mean, I guess and what the findings there were showing is that, yeah, you know, the groups coming from CAMHS are also a really high risk group for bipolar disorder, and there are lots of opportunities to capture that risk too. And the risk approach for bipolar disorder is far less advanced than it is for, you know, be it psychotic bipolar disorder, non-psychotic bipolar disorder, is less advanced than it has been for schizophrenia spectrum disorders. And so I think that, you know, that research is still very much in its infancy, but in many ways, so is some of the research on, especially for children and adolescents, for psychosis risk. So I think we still have a lot to learn about it, is the answer.
There's one question. Is there any research on the use of the Socrates for people with borderline personality disorder? Or is it very specific for psychosis as such, or is it can be used in a more broader setting, probably?
Yeah, I mean, the idea behind it is to bring a lot of structure to your assessment of psychotic symptoms, be they attenuated or full threshold. And so it's transdiagnostic, it can be used for any problem whatsoever. It's really just about giving you the structure for your assessment and your subsequent notes.
Perfect. Evidence, is there any evidence of reduced weight gain when metformin is combined with olanzapine to start off with? I mean, it's a bit difficult. So you said that there is, I mean, it prevents weight gain than actually having weight loss. I mean, people getting weight loss on it. One of the problems obviously here is that the GPs wouldn't prescribe it unless you're above BMI, and then you're a bit confused. How can we prevent? I mean, then I said weight gain, preventing weight gain, or is it weight loss? But that, as said, you said olanzapine as a second line management because of the metabolic side effects. Is it then justified to kind of prescribe olanzapine with metformin? That's the question.
So, I have some colleagues who do that when they, that they say, okay, I really feel I need to use olanzapine. I've tried these other medications and they haven't worked. And so this is where I'm at now. And, take those metabolic side effects very seriously. Don't want a young person piling on weight because, God, it's hard enough to be dealing with psychosis. On top of that, suddenly, your weight going up and you're going to deal with all of the stigma associated with the increased weight gain and the talking about, social withdrawal, feeling socially inadequate. I mean, your weight going up is a huge issue. So, I'm not someone who lightly says, let's throw in more medication. I just take it really seriously, those side effects. And so I think it's important to have that discussion with the young person, with their parents, when you're prescribing in particular olanzapine, saying, look, this is why I think we should go with this, but this is a very serious risk. And here are the approaches to dealing with them. We can talk about, referring you to a dietitian. We can talk about, is there any exercise physiotherapy available to our service or not? In most cases, not, unfortunately. And this is another option that I'd like to discuss with you. So I think it's about providing them with that information and supporting them to come to the best decision for themselves.
Thanks. And the next question is about negative symptoms and the use of low-dose amisulpride in people with negative symptoms. I think it's in reference to the differential effect where people kind of thought that, or early studies show that the lower dose is more effective for negative symptoms and higher dose for positive symptoms. What do you think of that? Asin, is there any evidence for that in children?
Yeah, so not in children, unfortunately, but that's true. I mean, that, in general, for maintenance in negative syndromes or predominantly negative syndromes, lower doses can be effective. And I think that brings up just the important point of, that you might have a particular dose when somebody's acutely unwell, but reducing that back down to a lower dose once the positive symptoms once they've rebated and somebody is not so distressed by them, and that a lower dose can be helpful just for the negative symptoms for sure. Unfortunately, no evidence base for children though.
Okay, one more question and I'll pass on back to Alastair. There's some evidence that this is regarding the CHR. There's some evidence that combining CHR approach with the Scandinavian basic symptoms approach were more accurate to predict conversion to psychosis. What's your comment on that?
Yeah, so I mean, so that's true. There is evidence that putting them together can increase your ability to predict later psychosis. I guess that doesn't address the issue, though, that very few people stand to benefit from that approach. So realistically, if you add in additional measures like basic symptoms approach, you're going to reduce the proportion to capture even further. And so I think the big lesson for the field is that let's not put all our eggs in one basket when it comes to detecting risk for psychosis. I think, we all went down the clinical high risk approach, and it was really valuable. It was, I think it really, so I don't want to, I want to be clear that I think the clinical high risk approach made us as a field think a lot about prevention rather than just for intervention. And that's fantastic. And I think that will be, its lasting legacies to say, we really started to think about prevention thanks to this type of research. But we need to diversify a bit. We need to think about not just one approach to psychosis risk prediction, because that's going to miss most of the cases.
Perfect. I think you're going to pass back on to Alastair. Thanks, Ian.
Alastair, you're muted.
Thank you, of course. Yeah, no, it's just to say in the last, we've only got a few minutes. If you could invite Matthias to put his camera back on as well, and really just to see if there are any further questions from the audience around all the. I think there was the one, Rajiv, one earlier that you were going to bring in at the end for Matthias.
Yes. About the neurodivergence, I think Ian, you touched on it as well a bit about autism and the prevalence. So I'll ask you this specifically. So how does neurodivergence fit into these models where trauma or insecure attachments aren't particularly present, basically? So that's the question.
Okay, yeah, so absolutely. When we look at interpersonal and relational factors, then obviously individuals, participants, people on the spectrum will not be expected to respond just in the same way. The short answer is we don't know, because a lot of the studies that look at these factors actually exclude people who are on the neurodivergent spectrum kind of thing. At the same time, we do know that individuals with early psychosis and autism can equally benefit from treatments that are well enough adapted kind of thing. But I think this is a very emerging question. I think I'm not sure there's a higher prevalence, but certainly we see a higher proportion in current presentations of children, young people, where there's also a query of autism as well as psychosis, and the literature is really, really sparse so I think clinical services do their best to adapt, but I'm not sure we have a clear evidence-based model for those. So, I think the rule of thumb is that if there's a presentation of psychosis, you attend to the psychosis. You don't assume that it's just an epiphenomena of an autism manifestation, but at the same time, a lot of the treatments, we don't really know what the most effective adaptations would be.
Thank you.
Ian, any comment on that? Or...
Yeah, I'm sorry, the sound went for me there, so I missed it. So I'll leave it with Matthias's comment. Unfortunately, I didn't hear that well either.
Just one, if I might, just one last question, primarily for Ian, but I'm interested in Matthias's view as well. But I mean, obviously, the finding that large proportions of people in CAMHS services end up with the diagnosis of psychosis, and I think you touched on that was also the case for bipolar illness, but would it also be the case for other significant adult mental health conditions? I'm thinking specifically about EUPD or complex trauma presentations. And thoughts on that, Ian? Yeah, so I mean, I think so. One thing to say, I suppose, that we're now looking at kind of broader level of outcomes. What are the outcomes for people followed over longer periods of time who come to CAMHS in general? And I think what the initial results on psychosis and bipolar disorder show is that CAMHS does this, and I see this as this amazing opportunity of capturing risk. And so does that risk stop at psychosis or bipolar disorder? No, I doubt very much it does, but we will have the data to show you sooner rather than later. But what it does is show, I think, ultimately it shows that if you set up and resource specialist mental health services for children and adolescents, not only do you provide really important opportunities to treat the problems of childhood and adolescence, but actually you create this opportunity to predict and I hope ultimately prevent some of the most severe chronic and enduring mental disorders of life. And so, that is a huge opportunity that we need to grasp for CAMHS. And of course, that involves, resourcing, funding, the research as well as the clinical services. Of course. Yeah, thanks, Ian. Matthias, any comments on that?
Well, maybe just to add, I think recent studies on at-risk mental states and those populations, both within intervention frameworks and observationally, also shown that at-risk mental states are a lot less linearly related to psychosis than we initially thought. So some of the transitions clearly lead into chronic and recurrent depression, personality difficulties, complex trauma and anxiety. And I'm not sure it's yet clear which indicators lead where kind of thing. And there was a big journal dedicated a whole special issue to the ethical issues of preventative interventions that are too specifically focused on psychotic experiences, when actually the actual transition into mental health disorders and recurrent mental health disorders may not be as specifically related to psychosis as we assumed.
Thank you very much. I mean, it sounds it's a rich area for further research and investigation, isn't it, and further development. Thank you both very much for your talks. I think there's been a lot of appreciation, and there's a lot of comments been coming through in a positive way on the chat. I'm going to hand back to Rachel to finish up though, but thank you very much indeed for your contributions.
Thanks very much. I'm going to start with thanks again. So thanks to all the speakers, including Susie and Rajiv and Alastair and Matthias and Ian. Thank you very much, all of you, for being here today. I think it's clear that we've heard and deepened our learning in a variety of ways. I think there's a lot now to go away and consider and do differently in terms of the way that we use and gather our data, in terms of our research, in terms of practice and sharing learning, and in understanding the opportunities and the limitations of the way that we understand our practice at the minute and the way that we our mental health services and systems operate. I think what's come out really strongly for me is that life course approach, and that prevention and early intervention are key within each area of that. So thank you to everybody for attending. Thank you to the speakers, and thank you to the team, Andrew and Andra and Ashley and Fiona and Nicola, for pulling this together today. It's no mean feat, and it's been amazing to listen to both the presentations and the discussion as well. And we will be able to share that with you. If you would like to continue to know what's happening in the world of early intervention psychosis in the programme itself, then do follow us on Twitter or email us or visit our website. And we are delighted to have you all with us today, and we hope that we will continue to have contact with you all in the future. Thank you all very much, and I wish you well and a happy lunch. All right, thanks very much now. Bye-bye.